We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect welcoming you all for today's webinar, Beyond the Partograph, Understanding the WHO Labor Care Guide, organized by FOG webinar, Advancing Academic Excellence in Fertility, Obstetrics and Gynecology in association with Foxy Society, Chennai, and also A4 Hospitals and Fertility Center, Chennai. It's my privilege to introduce the moderator for this webinar, Dr. Shweta Sundarajan, ma'am. Ma'am is the consultant obstetrician and gynecologist at A4 Hospitals at Valasaravakkam and also underwent Foxy Advanced Endoscopy training. And ma'am has underwent training in CCGDM course by PHFI, presented papers in national and state conferences. Ma'am has professional affiliations in life member of OXY and IAGE. Ma'am's field of interest is high-risk obstetrics and obstetric ultrasound and gynec endoscopy. I welcome you, ma'am, and I hand over the session to you.
Thank you for the warm welcome. So I wish everyone a very good evening. And I'm very happy to be moderating this session today, which is on the WHO Labor Care Guide. So we are moving beyond the partogram now. So as we all know, labor monitoring has evolved over the years. Initially, we started off with the Friedman curve, and then we had the old WHO partograph, and then there was a modification to the partograph, which I think all of us are using left and right. And but this partogram also comes with a limitation. We have the alert lines and the action lines, and the partograph that we use right now, it is very rigid, and it expects all women to dilate at a certain speed. So we expect all our mothers to dilate at least 1 centimeter per hour once they reach what is called as the active labor, which was previously 4 centimeter. And so the partogram that we are using right now still defines active labor to be at 4 centimeter only. But the same thing, the use of this partogram, I think, has led to a lot of unnecessary interventions, like using oxytocin augmentation for slow progress or early C-sections in otherwise perfectly healthy mothers and babies. So I think with the time and the evidence that we have now, we have moved from the old approach. So one size which will not fit all in labor, and the labor progress and monitoring should be more women-centered rather than fixing a certain speed of progress for every mother. So what we are moving towards right now is a more of a respectful maternity care. We give value to other aspects such as allowing a birth companion. We allow them to freely move around in the labor room. We offer a lot of pain relief options, and we try to keep the interventions to minimum. No unnecessary augmentation, no unnecessary C-section. So that's what all of us are moving towards, and we're all striving to give a good labor experience to the couple as such. So this shift is what has introduced a new WHO labor care guide. So we are moving past the old partogram. Partogram as such has also become outdated, and all of us are supposed to, we're all aware of the labor care guide, but how exactly are we going to plot it and how are we going to use it is what all about today. So with that context, I am extremely thrilled to introduce our expert speaker for today, Dr. Akela Vasdeva ma'am, who will take us through the core components of the LCG. Madam is a professor and unit chief in the Department of OBG, and she's also the chief consultant in the Division of Fetal Medicine at KMC Manipal. Ma'am received the DBT Crest Award in the year 2011-2012, and she's underwent 1 year of training in fetal medicine at London. She's currently practicing fetal medicine as a subspecialty in KMC Manipal since 2013, and she's also actively involved in undergraduate and postgraduate training since the year 2002. She has performed multiple diagnostic and therapeutic invasive procedures in fetal medicine, and ma'am has over 50 indexed publications in national and international journals. And apart from her teaching and academic activities, she's also her interests lie in Indian classical music and Bharatanatyam. Over to you, ma'am.
Thank you very much, Shweta, for that kind introduction. And I should also thank you for PPT to me in time, upon which I could do modification as per adding my experience to it. That was very helpful from your side, because I didn't have to do the basic job of preparing the basic PPT, and I could modify the PPT based on my experience. Thank you for the introduction. Can I
Thank you, ma'am.
start sharing? Yeah, can I start sharing my slide?
Yes, ma'am.
I think think it is a little slow. Is it? Is it hanging?
I,
Saiti, what happened?
ma'am's network is little low, I guess.
I think I rejoined. I'm so sorry.
Yeah, no issues, ma'am.
Yes.
No problem, ma'am. No problem. You can
Share
start
my.
sharing now, ma'am.
Can you see my
Yes, ma'am. We can see your desktop, but
yeah,
not the
just a
PPT,
minute.
ma'am.
Yeah.
Yeah, we can see the slides.
Yes.
Perfect, ma'am.
Okay. So I think this was already mentioned by Shweta. Respectful maternity care. All obstetricians, at some point or the other, we do know that the maternity care is more centered around the expected outcome of labor that we want. And at some point of time, we forget that woman loses her identity and she just becomes a case in the labor room. We realize the problem only when we ourselves become patients in labor room, or maybe one of our close relative or friend becomes a patient in labor room. How much respect a woman actually deserves in the labor room, we are most of the times unable to give that due to several reasons. I'm definitely not blaming, because I'm myself an obstetrician, but there's a lot of room, scope for improvement when it comes to respecting women in labor room. What is lacking is communication, explanation. Probably what we don't do is making them feel in control. What we mean is, many times the moment women enter labor room, they are in labor. The first feeling they have is they feel the lack of control on what happens on them. So that's what we should strive to remove from their mind. We should make them feel that they are in control of what is happening to them, and they can actually request for what they want. In addition to that, I have a personal feeling that our communication should be such that we make them part of the whole game. We gave them choices and ultimately make them feel that they are actually responsible for their decisions. So, if they are taking a decision to go on without any intervention for some more time, they want to wait. They should feel that they're given that choice and they're waiting because they wanted to wait. So this feeling of being in control of what is going on with me is what is completely lacking in most of the labor rooms. And probably a lot of problems can be avoided when you make them feel responsible for their decisions. Say, for example, they want to wait for some more time when everything is okay. They want to wait for a vaginal delivery, understanding that vaginal delivery has many advantages. They're going beyond a particular time limit. But when they feel that they have taken the decision, they naturally feel responsible for their decisions also. So This is one more thing which is important. So when they feel that they have been given the choice and they are an essential part of game when these choices are made, naturally they feel responsible for their decisions, and then a lot of litigations and a lot of problems can be avoided. Definitely not all, but to a large extent we can avoid issues that happen around the labor, because when we make them responsible for their decisions, obviously we tell them the small risk of uncertainties also which are involved in labor. And when you communicate these issues very well, they're already understanding that there are uncertainties, there are certain issues which may arise in second stage. So when they know all these issues, for example, there is a small chance of intrapartum fetal compromise or need of need of instrumentations, etc. When they're communicated about all this and they feel they're in control of their decision, I think things go much better during labor. So there are many things in the slide. I will not be reading what is in the slide because these slides, I believe, Shweta, are going to be given to everybody. If I'm right, am I right, Shweta?
Yes, ma'am, we can share it across, ma'am.
Can share it across. So I will not literally read what is on these slides. Rather, I'll share my experience. So basically, the aim of this labor care guide is continuously assess women and document what you have assessed and see if all is well. Now, what is well, that you have to define. You have already defined what is understood as well and what is understood as not well during labor. Now, when you realize, when you're documenting, you actually realize whether everything is going on okay or not okay. The whole idea of labor care guide is intervene only when things are not okay. As much as possible, do not intervene when you are within the limits of threshold. So that's all what is meant by using labor care guide optimally. And of course, it will support your audit. It will support your quality improvement in labor management. Of course, when do you start documenting labor care guide? It is only after the woman enters active stage of labor. So when is that? Not 4 centimeters, it is 5 centimeter or more. So why did we change this 4 centimeter to 5 centimeter? All PGs and junior consultants should understand this first. So the evidence suggested that up to about, in fact, even up to 6 centimeters, the rate of cervical dilatation was highly variable in large scale retrospective studies. So they realized that there is absolutely no fixed rate of dilatation till about even up to 6 centimeters actually. And only after 6 centimeters, they could give a particular median duration for the rate of dilatation. So that is the reason why they have kept active stage of labor at 5 centimeters. So what it means is that you should not intervene before 5 centimeters. So that's all it means. But does it mean that we don't monitor women in latent phase? No. Labor care guide is very clear. Even the moment woman enters labor, active labor, the woman enters the first stage of labor, then onwards she requires monitoring, preferably in labor room. Whether women in latent stage should always be monitored in labor room, or can a set of women be monitored in the ward or something like a HDU or a some other area? That is a matter of debate yet. But as of now, labor care guide is very clear, saying that even women in latent phase require monitoring. Once you initiate the labor care guide, that will support continuous monitoring throughout the first and second stage of active labor. So the issue here is there is labor will never accelerate until the cervical dilatation threshold of 5 centimeters is reached. That's why you should minimize medical interventions in the latent phase of labor. For example, starting oxytocin, doing cesarean, or sometimes starting misoprostol or doing whatever, doing AROM, etc. is not warranted, and you should always avoid the tendency to intervene in the latent phase of labor. However, there is always a clause here. If you can see here, provided fetal and maternal conditions are reassuring. So that is very important. It doesn't mean that a woman is very happy in labor room when she is in latent phase of labor for 24 hours. I think this is a very common scenario for experienced obstetricians. If you see a woman today morning at 9 o'clock in latent phase of labor, and then you come for rounds tomorrow morning, again she is in latent phase of labor, you know that all is not well. So experience also matters here, and you know that a prolonged latent phase beyond a particular point is to some extent associated with some kind of fetal compromise, maybe some meconium. If not meconium, the mother would exhaust. And if not mother, husband would exhaust. Mother would exhaust. So there are so many other issues. You cannot keep the patient in labor room beyond 24 hours in latent phase. Many times, our clinical judgment says to do something, isn't it? So that is one more issue. So individual clinical judgment also plays a very important role here. It doesn't mean that patient will forever remain in labor room in latent phase. But more often than not, what happens is the moment patient enters labor room and spends some 4 to 6 hours in 2 centimeters, we feel she's not progressing. So starts misoprostol, start oxytocin, do section. So all these tendencies should be avoided. That's what it means. So what is the time axis? So the first line is the actual time, and the second line will tell you how many hours have elapsed since she has come to labor room. Now it is divided into these columns, and for first 12 hours they have given option to enter the first stage, the active phase of first stage, and the last part is actually the second stage. So the moment she reaches full dilatation, you jump on the second stage like this, as it is seen in this slide. Now, what if suppose she stays at 5 centimeter for a long time, say 4 hours, 5 hours, and then she stays at 6 centimeters for another 5 hours, then obviously if it extends beyond 12 hours, the second LCG form should be commenced. That's what is recommended by the labor care guide. And they have given you a option of entering it in 12-hour or 24-hour format depending on the local practice. But all of us have a common experience that if somebody is 5 centimeters at 6:30 and she spends almost 12 hours in active stage of labor, we yes, some women are quite okay. And if your pain relief in labor is good, there would be good proportion of women who are quite happy in labor. But there are some who will never be happy in active stage of labor beyond 12 hours. Again, a clinical discretion and individual judgment of labor interventions is what is warranted here. You cannot strictly go by a rule here, because remember, 12 hours after reaching 5 centimeters is not a small duration. You need to monitor the fetus and mother very carefully. So there are many sections here. So section 1 is identifying and demographic information. So we'll go with these sections one by one. So section 1 is identifying information, and basically to know whether she is high risk or low risk pregnancy. And remember, this LCG is mainly meant to monitor low risk pregnancy. But still they have given a column for risk factors here. So you need to write down what all risk factors she has, maybe GDM, maybe gestational hypertension, maybe preeclampsia, or maybe stillbirth or whatever. And then parity and the labor onset and active labor diagnosis, the date and the time, and ruptured membranes date and the time. So this is what you're supposed to write in this section. Now, the very, very important aspect of the labor care guide is this section on supportive care. This is the section which is a welcome change in the partogram. This is a section which is actually what is showing as obstetricians we should be moving forwards in giving respectful maternity care to our laboring women, because it actually documents what you have been doing with respect to these issues. All obstetricians knew since a century onwards, all of us know that labor is much better with the companion. All of us know that every woman in labor needs pain relief and she deserves pain relief. All of us know that we should be giving her adequate oral fluids as and how much she wants. And all of us know that patient is not at all comfortable lying down supine all the time. But these things were never recorded on paper. All these were, under the table kind of thing, and we never literally recorded this on paper. Now, by using LCG, we are forced to record this on paper, and at least when we are recording it on paper, we realize there is an alert column here. I hope all of you are seeing this. Suppose there is no labor companion, it's an alert statement. That means something is not right. You need to act on it. If you are not offering her pain relief, it is an alert statement. Something is not okay. If she is not taking adequate oral fluids, something is not okay. And if she is all the time supine, strapped to her CTG, strapped to her toco, and you're going on monitoring her in supine position, that is not okay. So by documenting and by checking whether you are reaching this alert line, we are forced to make sure that we are giving adequate supportive care to laboring women. And that is what is the greatest advantage of using the new labor care guide. And all of us should make sure that these points are met with appropriately in our labor room. So the better, how good we are in giving labor companionship, how good we are in giving pain relief, how good we are in monitoring their oral fluid intake, and how good we are in encouraging the position what is comfortable for them. So that good will be the labor outcome, which is very, very evidence based. So that's what is the important point which you all have to focus on in the WHO labor care guide. So here, as you can see here, companionship. See, almost all women are going to say, "Give me a companion," isn't it? If you, uh, if you, if you don't talk about companionship at all, if your labor room doesn't offer, they all accept it. But if you offer a companion in labor, I don't think any woman would say no, because that's all what she wants. She wants someone to be with her all the time, and she's very happy if that person is somebody known to her, her mother, her sister, or her husband. So this is something I really don't think that anybody belongs to this D. Maybe 1% of women may decline companionship in labor. So whenever it is you're not offering and they don't have a companion, it is alert. Again, if she is not given any pain relief, that is an alert. So you should offer whatever possible pain relief in labor room that you could offer in your setup. It may be epidural with the lowest effective concentration of local anesthetic. It may be a opioid analgesic like pethidine, fentanyl. It can be at least a tramadol. It can be, I know of some labor rooms who are very freely giving Antinox. So there are many relaxation techniques in our own labor room in Kasturba Hospital. There are physiotherapy people who are posted in labor room. They're actually doing a fantastic job by teaching them the relaxation techniques, the muscle relaxations, breathing, music, and mindfulness, etc. And believe me, this really works wonders, because as doctors, we are literally, we are catering to so many things at a time. There are so many patients. We are unable to offer this one-to-one care. So we have realized that somebody with the patient and offering at least, if not pharmacological, non-pharmacological methods of pain relief, that would really make a lot of difference to the laboring woman. So that the experience that she goes through is good. Make sure that she is encouraged to take light diet as well as drink as and when she wishes during labor. So all women need not be, as far as possible, they should not be given IV fluids because it hinders their movement. It confines them to the bed and is most of the times not required. So you should allow them to drink as and when they want and how much ever they wish to. And position again, confining them to only supine position is said to be very, very uncomfortable. So they may want to walk around. They may want to, adopt some position of comfort that they are happy with. Some women are okay swaying. Some women are okay left lateral with the head up position, squatting, kneeling, whatever they want to do. As long as you're able to monitor the mother and the fetal well-being, the position of choice is always better to be adopted by mothers. So that's what is meant by supportive care. Now, coming to the care of the baby, so that is one thing here. It completely relies on intermittent fetal auscultation. Again, we all have this experience. It is literally impossible to have a doctor in the bedside auscultating for 1 full minute every 15 minutes during first stage of labor. Practically speaking, at least in our labor room, we don't have enough manpower to do that. So that's the reason why all low risk women will have CTG monitoring in our labor room, which definitely, scientifically speaking, CTG will give you many more additional things about fetal well-being, the variability for that matter, the type of deceleration, the cyclicity, the pattern recognition, so many other things are identified by CTG. However, in low resource settings, also in low risk women, all what is recommended by WHO is intermittent auscultation as long as you can give one-to-one care to the laboring woman. And by intermittent auscultation, all what you can check is baseline heart rate and deceleration. But remember, you should auscultate once in 15 minutes and at least 1 minute, and your auscultation should be soon after contraction. Any fetal heart rate less than 110 is an alert. Any fetal heart rate more than 160 baseline is an alert, and late deceleration is an alert. That means you have to continue to monitor for 1 full minute beyond the contraction. So if you can give that much care and that much intense monitoring with auscultation, you are most welcome to do that. And all what you need to see is baseline and deceleration. So what about amniotic fluid? Again, according to labor care guide, the thin meconium or even moderate meconium is not a reason for alert, but it is the thick meconium or blood-stained amniotic fluid is definitely a reason for alert. Fetal position, definitely a posterior position or a transverse position is an alert. That means a senior person has to be consulted on what to do next. But as long as the position is anterior, it doesn't become an alert issue in labor care guide. Caput also, 3 plus caput, grade 3 molding. These are all alert issues when it comes to care of the baby. So I think this is very clear. However, between grade 2 and grade 3 meconium, that is 2 plus and 3 plus, there is always a subjective variation. 2 plus and 3 plus caput, there is again a subjective variation. Even molding, I think all these issues, you cannot go by numbers. You have to assess the patient as a whole. You need to have a lot more information in your hand. What is the patient's height? How is the pelvis? What is the size of the baby? What is the attitude? Not only position, but also attitude. So there are too many things which come into play here, and therefore the clinical judgment and clinical analysis is very, very important, and your care should be according to the individual case scenario, not just based on these numbers. We all know that. But still, in a low resource setting, these are the alert issues that you should be worried about. So here what they say is no deceleration, early, late, variable. And you know that it is not that easy to distinguish this type of deceleration only based on intermittent auscultation. And again, as you can see here, non-significant, medium meconium, thick meconium, a lot of subjectivity here. So you should be careful. You should always assess the patient overall and individual labor as a different scenario. Each labor is different and your decision is different on each patient. So 1:1 care is needed for intermittent auscultation. And there are many things that you cannot see in intermittent auscultation. You cannot assess variability, the cyclicity, the fetal behavioral patterns, sinusoidal pattern, saltatory pattern, sequential changes in the fetal heart, differentiating typical from atypical variable, deceleration, the pattern recognition. And we should know that these limitations exist when you monitor the women only with intermittent auscultation. So I have deliberately put this because case to case, you have to sometimes alter the way you monitor the fetus. And fetal attitude is also very important in addition to position, and that is not recorded here in the LCG. And when you assess the labor, you should also assess the attitude, because if you have occipito-posterior position with a deflexed head, and you have a different scenario compared to occipito posterior position with the well flexed head. So, as an obstetrician, should also be able to assess whether the attitude is getting corrected on its own as the head is coming down with flexion. That's also equally important. Just because it is not mentioned in labor care guide, should not forget the clinical importance of these individual findings. Coming to the fourth section, care of the woman. Here, as you can see, pulse, systolic BP, diastolic BP, temperature, and urine. Now, in our labor room, we monitor mother's pulse and BP every hour. But according to the labor care guide, what they have mentioned is once in 4 hours. That again depends on the individual case scenario. And they have given very clear guidelines here. Pulse less than 60, more than 120, systolic BP less than 80, more than 140, diastolic BP more than 90. That means any patient who is going into shock, either due to dehydration or prolonged labor or sepsis or whatever blood loss or whatever reason, you should be able to pick up because the systolic BP starts going down. And any patient with preeclampsia, you should be able to pick up here hypothermia, hyperthermia, and urine. So it's important that if you have done a urine analysis in a preeclamptic patient, if urine protein is 2 plus, if a patient is prolonged labor, acidotic breathing, going into kind of obstructed labor, urine ketones are 2 plus. So all these are alert issues in the care of the woman. So as you can see here, 2 plus protein onwards, it is alert, and 2 plus acetone onwards, it is alert. However, as me and you know very well, we are not in an era where we push women into this type of acetonuria, isn't it? So what is mentioned in LCG is BP pulse every fourth hourly, but maybe a little more frequent monitoring is required. And remember, BP should be checked in sitting position. So all these are important issues. What about labor progress? Remember the old version of WHO Partograph emphasized a lot more on labor progress because they were very fixed on labor progress. According to the last version, uh, every woman, once she reaches active phase, the minimum rate of dilatation should be 1.2 centimeter per hour in a primary, 1.5 in a multi, on an average around 1 centimeter. If a woman does not progress, I mean, the rate of cervical dilatation is not 1 centimeter per hour, we all diagnose this as labor dystocia, and either we started oxytocin, we did AROM, we did a lot of cesareans. Now that is not what is expected out of us. What they are saying is a lot more levians should be given, lot more margin should be given for the duration of cervical dilatation. Now, where is this particular evidence coming from? I want to show you that slide first. So This evidence is coming from this particular large retrospective study, which was done. It was a multicentric trial which was done in US, and almost like more than several lakhs of women. Data was analyzed from the records, and they have taken only those women with normal outcome, all vaginal delivery, spontaneous onset of labor with normal neonatal outcome, and they realized that individual women take their own time to dilate. There's a huge variation when it comes to the rate of cervical dilatation. Before 6 centimeters, it is highly variable. You cannot say that she's dilating slowly at all, because somebody who dilates very slowly also may have a normal outcome. But once she reaches the stage of 5 centimeters, there is some sort of limit which can be put to the upper limit of cervical dilatation. However, the margin that they are giving is quite huge according to this paper. So this paper says that a woman can stay in 6 centimeters almost 5 or 6 hours. Woman can stay in 5 centimeters almost 5 to 6 hours. So I encourage all of you to read this paper. So remember, the one good thing is that in this paper, everybody had good outcome, normal outcome. All of them had vaginal delivery and they all had normal outcome. It actually ensures us beyond doubt that we should give time for women in labor. That's the one thing which is very clear from this study, that only based on duration we should stop ourselves from intervention. That's what is meant by this study. However, if you go in depth into this study, there are several limitations in these observations. So I still urge all obstetricians to use clinical judgment, which is very, very essential in individual case scenario. Now, based on that particular paper, predominantly based on that particular paper, these are the upper limits that was given to the rate of dilatation. So one more thing they realized is between 5 to 7 centimeters, women took a much longer time to dilate. And once they reached 7, 8, 9 centimeters, they took shorter and shorter and shorter time to dilate. But still, the upper limit of normalcy, according to this retrospective study, was 6 hours at 5 centimeters, 5 hours at 6 centimeters, 3 hours in 7 centimeters, 2.5 hours in 8 centimeters, 2 hours in 9 centimeters. This is really much, much, much more than what allowance we give in clinical practice. I'm not saying that you should really give this much time, that is 11 plus 3, that is 14, and then another 16, almost like 16, 18 hours after 5 centimeters is not something that is easy, that we can sit on a woman and wait like this. There are so many other factors come into picture. There is increased risk of infection. More than that, the woman herself may not tolerate labor if you really allow some 16 to 18 hours like this. However, having said that, um, this particular paper and the modification of dilatation, as mentioned in the LCG, reassures obstetricians one thing, that is, you should never take a decision solely based on time. Your clinical decision should be on how is the woman, how is the baby, rather than what is the time. So that's what is meant by following this guideline. So remember, these are the upper limits which should alert you. That doesn't mean that all women will take this much time at these individual centimeters of cervical dilatation. It is definitely not meant by that. But what it all means is that the 95th centile of duration at 5 centimeter was 6 hours. So that's what they're telling us. You wait, you give maximum allowable time at that particular cervical dilatation, as long as fetal heart is okay and the mother is tolerating. But I think without adequate pain relief, it is impossible that a woman can tolerate this labor. So equally essential is supportive care. It is not just the rate of cervical dilatation and allowing time. Equally essential is companionship, pain relief, adequate and very good pain relief, and the supportive care, allowing them to drink fluids, otherwise they'll get into dehydration. So there are so many other things that you have to do in order to give more time in labor. Only then we all will be able to achieve more and more vaginal delivery. That's all it means. So as as you can clearly see here, you should plot X for cervical dilatation, and you will do vaginal examination once in 4th hourly, not more frequent than that, and you will plot O for descent. So this is all the same what we used to do in the WHO partogram. What is special is there is a separate section for the second stage. So it is not that every woman you keep on doing PV once in 4 hours. So that again should suit each particular clinical case and in accordance with your own protocol. So sometimes, many times I feel once you induce labor, there is no need to do 4th hourly PV until unless you're taking a decision. As long as the mother is okay, fetal heart is okay, there is no need to keep on repeating PV once in 4 hours if you think the patient is progressing satisfactorily. So again, this frequency is also depends on the patient. So duration of labor, again, they have written very clearly in the same labor care guide that active first stage usually does not extend beyond 12 hours and usually does not extend beyond 10 hours. That doesn't correspond to the upper limit of alert line for, the cervical dilatation. So if you add all of them, it will be much more than 12 hours. So that itself means that you need to individualize the decision. So, that 1 centimeter per hour is definitely unrealistic. Please don't go by 1 centimeter per hour because a slower than 1 centimeter per hour dilatation rate is very common among those women who are having very good outcome and normal delivery. So that should not be an indication for you to intervene or do anything. So it doesn't really mean that you have to follow these thresholds as such. Even the labor care guide itself says that individualize the care and therefore it should be adapted in accordance with your own local protocol. And please remember that should not replace the expert clinical judgment of the care provider. So this is the original paper which has given all these upper limit of cervical dilatation rates. Now section 6 is medication. As this is almost the same as the old partogram, you have to mention how much oxytocin you are giving, what medication you are giving, what IV fluids you are giving. And this is again very, very important, the new thing that is added in the labor care guide, that is shared decision making. It's very, very important that you don't decide for them. Very clearly you explain them what you are doing, how is the progress, what is expected and what is happening, what is the purpose of your intervention and what you would like to do. So everything has to be clearly explained to her and her companion, and the subsequent course of action should be very, very clear, and they should be feeling that they are also very important part of that decision making. So that's what you're supposed to enter here in the assessment and your plan. For example, you say we have discussed everything, we are continuing the monitoring, or you say we have now ordered urine protein, or you say we have taken a decision now to augment labor because the alert thing is being reached. Say for example, she is at 5 centimeter for more than 7 hours now. So definitely that is because of lack of contractions. And so you have decided, you have explained the woman and her companion, and you have taken a decision to augment labor with oxytocin, or you have decided to do AROM, or you have decided to put vacuum, or you have taken a decision for cesarean. So all these decisions, plans should be recorded. It should be a shared decision making. That's what is very, very important. The times have changed. See, the original modified WHO partogram, those were the days when women used to die of neglected and prolonged labor, obstructed labor, lot of maternal perinatal mortality, morbidity. So the focus was mainly on the rate of cervical dilatation, and you need to take appropriate referral at the right point and take an action to prevent perinatal mortality. But now the intention of labor care guide is completely different. See, there are many social demographic changes and evolutionary events which have taken place. For example, women are older, women are heavier, and the babies are also bigger, the head size is bigger, so the labor is taking much more time. The normal labor is taking much more time, even among those who are delivering vaginally. We are not meaning that among those who are going for section, even among those who are going to deliver vaginally with the good outcome also, the labor is taking much more time than 50 years ago. So the intention of labor care guide is actually to avoid unnecessary and premature interventions like section, AROM, oxytocin, etc. And the intention of LCG is also to give respectful maternity care by giving adequate supportive care. Do not intervene unless you meet the criteria in alert column. So these are many differences between the modified WHO partograph versus WHO. I think that's very clear in this slide, but I have dealt with all these things individually. Watchful expectancy is all what is needed because labor is, after all, a physiological event. A policy of active management of labor for prevention of delay is not recommended. For example, somebody is 4 centimeters for 6 hours, you do AROM is a very common practice, but if you really follow labor care guide, you should just allow them with her and don't do anything. But at the same time, I'm not really saying don't do anything is always right. So that all those decisions depend on the individual case scenario. But simply because somebody 4 centimeter for 4 hours and they did not progress doing AROM is completely discouraged by labor care guide. Again, routine episiotomy, liberal episiotomy is not recommended by labor care guide. Application of manual fundal pressure is also not recommended. So do we agree with everything? You need not. Definitely no. You don't really have to follow word to word what is given in any document, isn't it? Ultimately, clinical management is labor management is, I would say, an art rather than science. In fact, the entire medical practice, according to me, is more art than science. So you can't really go by, line by labor care guide or partogram. You'll have to see individual case scenario. For example, there's absolutely no need of any pelvimetry, but we all know by experience that you need to assess how big is the woman first. How big is the woman? How big is the baby? There has to be some proportion there. What is the attitude of the head? Where is the head? So everything matters. The relative cephalopelvic disproportion is completely discarded, and I personally don't agree with that. I feel you need to have an overall assessment of proportion of pelvis and the baby and the mother, and routine cardiotocography is not recommended. Even on labor admission also it is not recommended. So probably there are many issues which are matters of debate here, and I think in your own setup what is best for your patient you should do. You don't need to follow any document word to word like that. And remember, LCG is primarily designed to be used for the care of apparently completely low risk pregnancy in a primary care setup. Women at high risk of developing complications may require additional specialized monitoring and care. That is written very clearly in LCG. Do we know what Indian women and their family expect from us? We really don't know. We have not systematically assessed what our women want and what do their family want. In fact, many of them do not have adequate background scientific knowledge to understand the uncertainties surrounding labor. They are not yet well trained to adapt themselves as a labor companion. First, we need to educate our patients, women, and their companions on the labor events. How does labor room look like? What do we do there? First, they need to be educated about this. They should also know that there are many things uncertain during labor. So, medical emergencies are never understood by lay people. They may inadvertently think that we are not doing what is needed. So, there are so many problems may arise when we allow companions in labor room. So we should all be ready for that. So we should also educate them that despite giving our best care, also things can go wrong. What all can go wrong in labor? If you make them understand very clearly, then it is easy to allow companions in labor. Labor room environment is something that a lay person takes they have it is very difficult for them to really uh, understand what we're doing in labor room. They need to be first educated about it, what they expect from the companion. And prior to any rollout of adapted LCG, you should pilot it in your own setting. And you should actually encourage end users' feedback. Who are the end users? Doctors, nurses, and patient and companions. All four of us should give feedback. Only then it can we can successfully adopt it to our place. And keep the LCG focused on labor monitoring. Don't incorporate too many new variables into that. And providers in facilities with high workload and few resources. You have 1000 deliveries per month. They may consider LCG very time consuming or less feasible, which I completely agree, because what they are doing is an excellent job in the available resources, and probably that is really a good service. At that point, it is impossible for them to incorporate LCG. Lot more manpower, lot more resources are needed to incorporate LCG in such high workload setup. And remember one thing, LCG is not a medical record. It cannot replace your medical record. It is only an adjunct for you to improve respectful maternity care and supportive care. So this is a very typical example of a plotted WHO labor care guide. As you can see very well in the freely available document. So I'll share this with all of you. You can learn this. Thank you very much, and I welcome questions.
Thank you, ma'am, for the very crisp and clear presentation. Do we have any doubts? I think one more advantage of this LCG is that it is very clear, and all the normal abnormal values, everything is mentioned right there. So anyone can, even our staff nurses or the duty medical officers, I think all of them can be trained to use that, ma'am. Not a necessity that it has to be maintained by the gynecologist because of our time constraints. Any doubts? Uh, we have a doubt, ma'am. Do we still have to write our notes in the progress notes, even if we plot the labor care guide?
Yes. Can you hear me?
Yes, ma'am. Yes, ma'am.
Actually, there's some problem with my Zoom, but I hope you can hear me.
Yes, ma'am.
It is very clearly mentioned in the LCG itself that it is not a medical record.
Yeah. So it is not a replacement to our progress notes. We have to still document everything in the case sheet. And the second stage of labor, ma'am, for is there any difference between multigravida and a primary, or we can wait for 3 hours for irrespective of the obstetric score, ma'am?
Akila ma'am, he's having some network issue. Ma'am will be
Okay.
rejoining again.
Okay.
Hello.
Yes, ma'am. Yes, ma'am.
Sorry, there is a lot of disturbance in the moment I try to do
Uh,
something, it is just getting off.
Ma'am, your audio is not clear, ma'am.
Uh, yes. Uh, so the LCG itself says that we should not use it for medical records. Hello? Hello?
Yeah, yeah, ma'am. I think your
Hello?
audio was not clear then, ma'am. So,
Yeah. So
yeah, I think you meant to
definitely,
say as a
yes, yes, it is not used as a replacement for medical record. It is not used like that. Yeah.
And as far as second stage is concerned, irrespective of whether or not they are on epidural, it's 3 hours for a primary gravid and 2 hours for a multi,
It
right?
is 3 hours and 2 hours. Yes.
Okay. Thank you, ma'am. So I think we're done with the doubts. So yes, I think it's high time we stop considering labor as only a clinical event. It is for the couple. It's a very personal journey, and I think we all should also try to shift our mindsets to respect their choices and preferences. Doesn't really mean that we have to do everything that they say, but I think it's time we keep them informed and take their choices also into consideration. And I think the WHO website has a very clear guide on how it has to be plotted with all the examples. So I think all labor rooms should start shifting slowly from the routine partogram to LCG. Thank you for spending your time with us today, ma'am.
You're most welcome, Shweta.
Can we close the session? I think we are done with the doubts as well.
Yes. Okay. Thank you,
Yeah.
Shweta. Thank you.
Thank you, ma'am.
Bye.
Yeah. Sahiti,